Good morning, everyone. This is the third lecture of the female genital tract pathology series, and today we will be discussing uterine corpus diseases. This is a representative image of the endometrium in the upper half and the myometrium in the lower half. The endometrium is composed of glands and intervening stroma. The myometrium is composed of smooth muscle cells. The endometrium has two layers. The most superficial one is the functional endometrium. This is the layer that undergoes changes during the menstrual cycle. The deeper half is the basalis layer, and this is not as responsive to hormonal changes as the superficial or the functional layer is. Today we will be discussing these entities: endometritis, adenomyosis, endometriosis, abnormal uterine bleeding, and some proliferative lesions, namely endometrial hyperplasia, endometrial carcinoma, endometrial polyp, leiomyoma, and leiomyosarcoma. Endometritis is inflammation of the endometrium. This could be acute or chronic. Patients present with fever, abdominal pain, and menstrual abnormalities. Endometritis carries an increased risk of infertility and ectopic pregnancy due to the scarring effect on the fallopian tubes. Again, endometritis could be acute or chronic. Acute is diagnosed when neutrophils are seen on microscopic examination, and chronic endometritis is diagnosed when plasma cells are seen. Please notice that neither neutrophils or plasma cells are seen normally in the endometrium. There are many causes of endometritis. Some of them are infectious and some of them are not. Infectious causes include Neisseria gonorrhea, Chlamydia trachomatis, mycobacterial infections. Non-infectious causes include retained products of conception and the presence of foreign bodies such as intrauterine device. Retained products for conception refers to placental tissue present after the pregnant woman undergone abortion or miscarriage. These retained fragments carry a risk of increasing infections because they undergo necrosis. As I mentioned, histologically, neutrophils in acute endometritis or plasma cells in chronic endometritis. There are some morphology clues to the etiology. For example, lymphoid follicles indicate Chlamydia trachomatis infection. Granulomas imply tuberculosis. Tuberculosis occurs in immunocompromised patients such as HIV and bone marrow transplant patients, as well as people who live in endemic areas. The removal of the underlying cause, such as intrauterine device, could result in cure. Adenomyosis refers to the growth of basal layer of the endometrium down into the myometrium. In other words, the endometrial glands, which should normally be reserved to the endometrial lining, go and embed themselves within the myometrium. These glands are from the basalis layer, which does not undergo cyclic bleeding because they do not respond to the cyclic changes in estrogen and progesterone. Adenomyosis causes menorrhagia, dysmenorrhea, and pelvic pain. This is a histologic image of adenomyosis. Notice the glands and the small stromal cells around them are invading through the myometrium, which are indicated by the green arrows. Interestingly, whenever the glands invade the myometrium in adenomyosis, they induce hyperplasia of these muscle cells. That's why, macroscopically, the uterus is very thick and boggy. Endometriosis, on the other hand, is the presence of endometrial glands and stroma outside the endomyometrium. It can happen in the anywhere basically in the body, but most commonly in the pelvis, as we will see later. It happens in 10% of all women. It causes 50% of infertility cases, and usually it's multifocal. As previously mentioned, it can happen anywhere in the pelvis, most commonly the ovary. It can also affect the fallopian tube, the round ligament, and the broad ligament. It can also occur outside the pelvis, on the colon, and even in the lung. Several theories try to explain why endometriosis occurs. One of them is regurgitation theory, metaplastic theory, and vascular lymphatic dissemination theory. The regurgitation theory implies that during the menstrual cycle, fragments of the endometrial glands and stroma will regurgitate through the fallopian tube into the pelvis. The metaplastic theory implies that the coelomic epithelium of the pelvis and abdominal cavity will undergo metaplastic differentiation towards endometrial glands and stroma. And the last theory, the lymphatic dissemination, indicates that endometrial glands go through the blood vessels and lymphatics to other sides of the body. While the first two theories explain why endometriosis occurs in the pelvis and in the abdomen, they do not explain how sometimes endometriosis can be seen in the lung. However, the third theory, which is the lymphatic vascular dissemination theory, could explain such occurrence. The endometriotic tissue in endometriosis is abnormal as it has high levels of inflammatory cytokines, and this explains why patients suffer severe pain. Also, they have high estrogen content due to high level of aromatase, which converts androgens into estrogen. Unlike adenomyosis, glands in endometriosis are always functional, meaning they respond to the hormonal changes seen in the menstrual cycle. A curious morphologic change seen in the ovary affected by endometriosis is called the chocolate cyst. This happens because when the ovary is affected by endometriosis, and since this is a functional endometrium, it can bleed into a cyst. The blood will transform from red color to brown color, hence the name chocolate cyst. The histologic diagnosis of endometriosis requires the presence of two of the following three features. These three features are endometrial glands, endometrial stroma, and hemosiderin pigment. This is a representative image showing all three criteria of endometriosis diagnosis. The green arrowhead points at the glands. The red arrow points at the stroma, while the blue arrow points at the hemosiderin pigment, which is this red-brownish pigment seen in the stroma. Clinically, women with endometriosis present with severe dysmenorrhea and pelvic pain. They have high incidence of infertility. They can have pain upon defecation if the endometriosis affects the colon, as well as pelvic discomfort. Moving on to abnormal uterine bleeding. This is one of the most common presentations to the OBGYN clinic. Abnormal uterine bleeding has three major subtypes, or three major clinical presentations. Menorrhagia, meaning heavy menstrual bleeding. Metrorrhagia, meaning irregular menstrual bleeding. And postmenopausal bleeding is bleeding occurring after menopause, and this is basically the most serious one. Causes of abnormal uterine bleeding are heavily dependent on the age of the patient. For example, during adolescence and perimenopause, anovulatory cycles are very important etiologies for abnormal uterine bleeding, while postmenopausal bleeding is more worrisome and should indicate more investigations to rule out more serious problems such as carcinoma. The pathophysiology of abnormal uterine bleeding can be categorized into four major groups: failure of ovulation, inadequate luteal phase, contraceptive-induced, and endometrial abnormality, such as polyp or carcinoma. This is a schematic presentation of the changes that occur in the menstrual cycle. In the first half, or the follicular phase, estrogen is the major hormone. Estrogen causes proliferation of the endometrial glands. The second half of the menstrual cycle is characterized by a high level of progesterone, indicated by the black line, and lower level of estrogen, which is indicated by the blue line. Progesterone opposes the effect of estrogen and induces the glands to be more secretory and more receptive for the incoming zygote should there be any pregnancy. So what happens in an ovulatory cycle is, since ovulation does not occur, estrogen will go on unopposed. This unopposed estrogen will induce more proliferation than normal. As proliferation continues, the blood supply to the uterus will not be enough to maintain or to sustain the life of these glands, so they start shedding. And this is basically the underlying cause in the vast majority of cases of abnormal uterine bleeding in women in the perimenopausal periods. The most common proliferative lesions of the uterine corpus are endometrial hyperplasia, carcinoma, polyps, and smooth muscle tumors. They all tend to produce abnormal uterine bleeding as one of their earliest manifestations. Endometrial hyperplasia, as we discussed previously, is most commonly caused by unopposed estrogen. This can happen in cases of failure of ovulation, close to menopause in perimenopausal women, or in girls undergoing puberty. Prolonged administration of estrogen, such as hormone replacement therapy in perimenopausal women undergoing or suffering from hot flashes. Ovarian tumors that secrete excess estrogen, and obesity, as excess adipose tissue has the ability to convert androgens into estrogen. The severity of hyperplasia correlates with the duration of estrogen exposure. The more prolonged the estrogen exposure is, the more severe the hyperplasia is. Endometrial hyperplasia carries a certain risk of transformation into malignancy. This risk of cancer transformation is highest in the presence of atypia. For example, complex hyperplasia with no atypia carries only a 5% risk of transforming into malignancy. That's why they are treated with watchful follow-up. On the other hand, complex hyperplasia with atypia carries a 20 to 50% risk of transformation into malignancy, and that's why its treatment is hysterectomy. The gene P10 is vital in the development of carcinoma through this pathway. The upper left image shows simple hyperplasia. The right-hand side image shows complex hyperplasia without atypia. And the lower left image shows complex hyperplasia with atypia. And this, as we mentioned, carries a cancer risk of 20 to 50% and should be treated with hysterectomy. Endometrial carcinoma, it's the most common cancer in the female genital tract. It has two major subtypes, endometrioid, related to estrogen excess, and the pathway we mentioned in the previous few slides, hyperplasia, and then atypia, and then invasive malignancy. The other major subtype is serous carcinoma. It affects older women in the setting of atrophy. To summarize, endometrioid carcinoma happens in the setting of hyperplasia. Serous carcinoma occurs in the setting of atrophy. Endometrioid is much more common, representing 80% of all endometrial carcinoma cases. There are several risk factors related to estrogen excess, including obesity, infertility, and exposure to unopposed estrogen. Other risk factors include diabetes and hypertension. And as we mentioned previously, PTEN and DNA mismatch repair genes are important. PTEN is involved in the Cowden syndrome, which carries increased risk of malignancy in breast, thyroid, and endometrium. TP53 is rare and occurs late in the pathogenesis of this tumor. On the other hand, serous carcinoma does not carry PTEN and DNA mismatch repair gene mutations as much as endometrioid adenocarcinoma does. However, p53 mutations are very common in serous carcinoma, and in fact, they are used for the diagnosis, as we shall see soon. These two images are for or represent endometrioid adenocarcinoma. The malignant glands look kind of similar to the normal endometrium. Serous carcinoma, on the other hand, looks like papillae that are lined by highly malignant cells, and the right lower image shows diffuse positivity for p53. Positivity is indicated by these dark brown nuclei. Notice that the stroma in between these nuclei is actually negative, implying that the malignant cells are positive for p53, which is diagnostic for serous carcinoma. Clinically, patients present with abnormal vaginal discharge, abnormal bleeding, or uterine enlargement. And as most tumors in the female genital tract, stage is the most important prognostic factor. Endometrial polyps are benign, polypoid, or sessile growth composed of dilated glands and monoclonal stromal cells. The polyps invariably contain thick-walled blood vessels. They can cause bleeding in postmenopausal women. They carry a very small risk of cancer. Their clinical significance lies in the fact that they should be differentiated from carcinoma, and that's why hysteroscopic examination with pathologic examination of the biopsy is vital in reaching that diagnosis. This is a histologic representation of a polyp. Notice how dilated the glands are, and there are some small blood vessels on the right-hand side of the image. Leiomyoma is a benign tumor of smooth muscles. It is the most common benign tumor in females. It's more common in people of African descent. It responds to estrogen. That's why the pain and the bleeding associated with them are changing during the menstrual cycle, and that's why they shrink postmenopausally due to the severe decrease in the estrogen concentration in the blood. Leiomyomas can be multiple or single. They can be submucosal, directly below the mucosa. They can be intramural in the wall or subserosal, just below the serosa. They can also be pedunculated. Leiomyomas could be asymptomatic or could be symptomatic. The symptoms usually are abnormal uterine bleeding, pelvic heaviness. Sometimes they can undergo necrosis, which results in severe pain. This is a non-complication, especially during pregnancy. Leiomyomas almost never transform into malignancy, regardless of how large or how numerous they are. The malignant counterpart of leiomyoma is leiomyosarcoma. It is a malignant neoplasm with smooth muscle differentiation. It arises de novo, not from a previous leiomyoma. It affects postmenopausal women, and unlike leiomyoma, it is usually solitary, while leiomyomas could be single or multiple. Grossly, the tumor is soft, unlike leiomyoma, which is firm. It shows a combination of necrosis, atypia, and increased mitosis. These are the three features that we use to differentiate between leiomyoma and leiomyosarcoma. It has a tendency to metastasize to the lungs, and the 5-year survival is only 40%. This is a histologic representation of leiomyosarcoma. Notice the pleomorphism, or the atypia, and the increased mitotic figures in this image. By the end of this talk, I would like to thank all of you for listening. Please stay safe, and if you have any questions, please do not hesitate to ask. Thank you. The upper left image represents a uterus afflicted by several leiomyomas. The right lower image shows a histologic picture of leiomyoma. The cells are spindly. There are no obvious cell borders, and the nuclei are cigar-shaped with blunt ends, which is characteristic of smooth muscle neoplasms everywhere in the body.